Omphalocele we already discussed. So this is an example of omphalocele. So basically, abdominal content herniates through the umbilical area. Anatomy of the abdomen, we don't have to go. It's just for your reading. It is included in the content, but you can read it once, but I will not go over anatomy in detail. The regions we all know, 8 regions, pretty basic. Planes, how different planes divide and convert them into regions. Muscles of the anterior abdominal wall: external oblique, internal oblique, transversus abdominis, rectus abdominis. You guys can read it yourself. Is origin, insertion, there is no concept you need for that. Layers of the anterior abdominal wall is important, okay, because if you are a surgeon, you need to know the layers of anterior abdominal wall. So let's say if you are doing surgery, they can give you actually a situation that you are a resident and you are a surgical resident, and the surgeon asks you to start a surgery on a patient, and what will you see in the correct order. So if you are doing abdominal wall surgery, so number 1, you will see skin, then superficial fascia, external oblique muscle, internal oblique muscle, and most commonly the question of the content will be about hernia surgery. This is a clue. Transversus abdominis muscle. So skin, superficial fascia, external oblique, internal oblique, transverse abdominis muscle, extra peritoneal fat, and then interperitoneal area. So you need to know them in the order. Peritoneum, this is for your reading. It has parietal layer and visceral layer. Visceral layer is basically covering viscerals, and parietal layer is the outer layer of peritoneum. So there are some images. Epiploic foramen is important. It's also called foramen of Winslow. This is the only communication between greater and lesser sac. Now, what are the boundaries of epiploic foramen? So they will not ask you any of these boundaries, but you should know, because there is one thing which they will ask you, which is content of epiploic foramen. That is the most important question. But let's go over the boundaries. Anteriorly, hepatoduodenal ligament and hepatic portal vein. Posteriorly, inferior vena cava. Superiorly, caudate lobe of the liver. Inferiorly, first part of the duodenum. Like I said, they will not ask you about the boundaries. They will ask you the content. So here, this is the epiploic foramen. So during the surgery, you can actually put your finger and compress this gastroduodenal ligament. And this is the only communication between greater and lesser sac. So you can do Pringle maneuver. At this point, you can compress. Let's say if there is a bleeding during the surgery, you can actually put your finger here and compress this area to stop the bleeding. This is called Pringle maneuver. Used to clamp hepatoduodenal ligament and interrupt the flow of blood through the hepatic artery and portal vein in order to control the bleeding during liver resection or managing liver trauma. So you can actually clamp it too. But let's say if the clamp is not available, you can actually put your finger in and apply pressure. Pringle maneuver. Next important topic is what are so interperitoneal organ, they will not ask you question from this, but retroperitoneal organ, you should know all of them. What are the retroperitoneal organ? You should know all of them. So there is a famous mnemonic I'm sure you guys are all aware about, SAD pucker. So what are the retroperitoneal organ? The mnemonic is SAD pucker. SAD, S is suprarenal gland. Suprarenal gland. A is aorta. D is second portion of the duodenum. P is pancreas, except tail of the pancreas. U is ureter. Colon, and colon will include ascending and descending colon. K is kidney. E is esophagus, thoracic part, and then R is rectum. Now, why retroperitoneal organs are important? Because the problem is if there is an injury to the retroperitoneal organ, the patient can bleed to death. So that's why they are very, very important. So let's say if there is a injury to the kidney, a patient can develop hematoma or bleeding retroperitoneally in the peritoneal space, and they can bleed to death. That's why they are very important. So you need to know all the retroperitoneal organ, because according to the site of surgery, if you know this organ is retroperitoneal, then you can suspect the complication. So from clinical standpoint, they are very important. Next is femoral triangle. Again, they will not ask you about boundaries. They will ask you the content is more important. So femoral triangle boundaries: superior internal ligament, medial adductor longus muscle, lateral sartorius muscle. Floor is iliopsoas, pectineus, adductor longus muscle, and roof is fascia lata. So you can see this is femoral triangle. This. So on the lateral side, you can see this is sartorius muscle. The medial side, adductor longus muscle. Look at left, and the superior part is inguinal ligament. And the inside, you can see that pectineus muscle is here. But let's focus on the content. So from lateral to medial side, the mnemonic is navel. N-A-V-E-L. N is nerve. This is the nerve. A is artery. Lateral to medial side. So we are moving in this direction. Laterally, this is lateral. This is medial. Lateral to medial, nerve, artery. V is vein. E is empty space. And L is lymphatics. So the contents are important, lateral to medial side. Next is femoral ring. So again, they will not ask you about the boundaries, but anteriorly there is inguinal ligament. Posteriorly, pectineus muscle. Medial is base of the lacunar ligament. Lateral is femoral vein. So femoral ring is located somewhere here. Again, femoral ring is not very important. They will not ask you about that. Femoral hernia is very important. Why? Because there is a high risk of strangulation with this kind of hernia. So femoral hernia is more common in female. Femoral ring is a point of potential weakness of abdominal pelvic wall. So the bowel loop will protrude into the femoral canal and strangulate. It is below and lateral to pubic tubercle. So this is pubic tubercle, and this is below and lateral to pubic tubercle. Why it is important? Because if you compare femoral hernia with inguinal hernia, so inguinal hernia is more medial and superior than femoral hernia. So you can see this is pubic tubercle, pubic symphysis. This is pubic symphysis here. So in terms of femoral hernia, you can see this is below and lateral. This is femoral hernia. Again, more common in female, high risk of incarceration, strangulation. But in case of inguinal hernia, more medial and then more superior compared to femoral hernia. So if they give you all the option that patient has hernia, female patient, The answers are direct. Number 2, indirect. 3 is diaphragmatic hernia. 4th is umbilical hernia. 5th is femoral hernia. And if they give you if the patient is complaining of pain, he's not able to move the gastric content or the herniated content move backward. So femoral hernia is the kind of hernia which has high risk of strangulation. So the answer will be femoral. Just a quick request about this mnemonic in the femoral region. So we have this femoral triangle. So on the lateral side, this is the sartorius muscle. Medial side, this is the longus muscle. Superiorly inguinal ligament. And if we look at the content of this femoral triangle from lateral to medial side, so this is lateral side, this is medial side. If we look at the content from lateral to medial side, the mnemonic is navel. From on the lateral side, first is nerve. So you can see this is the nerve. Second is A is artery. Third is vein. Here there is empty space, and then you will find some lymphatic on the more medial side. So this is a way to remember the content of femoral triangle. From lateral to medial side, nerve, artery, vein, empty space, and lymphatics.